Let's be honest, chronic gastrointestinal cases are exhausting. You've seen the dog, you've seen the worried owner, and you've felt the frustration of a clinical presentation that feels more like a guessing game than a diagnosis. However, we are moving into a new era of clarity. These 2026 guidelines advocate for a critical shift in our analytical narrative. We are moving away from the narrow, often misused term IBD toward the more accurate umbrella of chronic inflammatory enteropathy. CIE isn't just a new name. It's a strategic framework that acknowledges the complex interplay between the immune system, the microbiome, and genetics. By adopting this broader categorization, we move from empirical guesswork to a structured, evidence-based diagnostic plan. The 2026 guidelines prioritize strategic categorization as the first clinical fork in the road. This ensures we don't under-triage unstable patients or over-diagnose stable ones. This system allows us to prioritize our resources and circumvent delays in cases where the gut is actively failing. We use criteria such as clinical activity scores, weight trends, and biochemical markers to determine the patient's tier. This categorization dictates our diagnostic timeline. While we have the luxury of time with a CIE1 patient, CIE2 patients require immediate escalation. For these unstable patients, the guidelines urge us to move quickly, because every day of nutrient loss counts. Once the tier is established, we begin the rigorous exclusion phase. CIE remains a diagnosis of exclusion. Skipping the foundational minimum database is a common pitfall that leads to detrimental misdiagnoses of primary GI disease when the issue is actually metabolic or infectious. We must rule out the mimics before confirming inflammation. Dietary management is the cornerstone of CIE therapy, boasting response rates of up to 89%, but in many cases the plate is also our most powerful diagnostic tool. The guidelines explicitly mandate a patient-first approach for stable dogs. We must conduct at least 3 properly designed dietary trials before pursuing invasive biopsies. The key differentiator for food-responsive enteropathy, FRE, is the speed of response. While some cases take longer, a positive response is typically seen within 10 to 14 days of exclusive feeding. If the symptoms resolve in this window, we have a definitive diagnosis of FRE, circumventing the need for anesthesia and invasive diagnostics. When trials fail, or if we are dealing with a CIE2 patient, endoscopy and histopathology remain the gold standard. This step is non-negotiable for unstable patients or those where we suspect neoplasia/lymphoma. To ensure a diagnostic sample, we must collect 10 to 15 biopsy samples per site from both the duodenum and the ileum. It is vital to include ileal biopsies, as research shows only a 17% concordance between duodenal and ileal lesions in some cases, meaning if you skip the ileum, you may miss the diagnosis entirely. Management is a long game. We define remission as a clinical score reduction of greater than 75%, while a partial response falls between 25 to 75%. Longitudinal assessment is the only way to ensure we aren't just masking signs, but actually healing the mucosa. The take-home checklist for gut health: weekly clinical scoring, track clinical and fecal scores religiously, nutrition monitoring, bi-weekly body and muscle condition score checks, albumin surveillance, mandatory every 1 to 2 weeks for PLE cases until stable, dietary integrity, zero tolerance for non-therapeutic treats or table scraps. CIE management is a marathon, but with precision and patience we can reclaim the dog and the owner's quality of life. Let's take the guesswork out of the gut.